Hi everyone. Good evening. Welcome you all to the next episode of UVATS webinar, the 2.6. On behalf of UVATS Society, happy to see all of you on the weekend. But before we start off the webinar, I would like to request you all to participate in the poll. We've actually, I think, hope most of you have received the mail and the WhatsApp also regarding the venue and how many people are attending in Jammu and otherwise, because we want to plan the logistics since there was a break in between. So please take part in the poll, and we would expect all the responses by tomorrow. So now Partha will take over and talk about our moderators, and the webinar will go on. Thank you.
Thank you, sir. Hope I'm audible, no?
Yes.
Yeah. So, good evening, everyone. So, welcome to the webinar 2.6. So, today we have two moderators from Delhi. Our first moderator is Dr. Neha Jain. So, Neha is a vitreoretinal consultant and UVA specialist at Jain Eye Hospital and Laser Center, Shalimar Bagh, Delhi. She completed her long-term vitreoretinal fellowship at LV Prasad Eye Institute. She has been recognized for her academic contribution with several prestigious awards, including Kalicharan Gold Medal for Best Paper Presentation, Best Free Paper Presentation in the cataract category in Delhi Ophthalmological Society meeting, and Dr. Narsingh Rao Award for Best Free Paper at the 12th USI Meet in December 2012. In recognition of her contribution to the field, she was also honored with Women's Achievers Award in July 2019. Our other moderator is Dr. Tania. Dr. Tania Jain is a consultant in vitreoretina, uveitis, and retinopathy of prematurity at Dr. Shroff's Charity Eye Hospital, New Delhi. She completed her DNB from Sadhguru Netra Chikitsalaya, Chitrakoot, followed by a vitreoretina fellowship at Shroff's Charity Eye Hospital. She further pursued advanced training with a diploma in uveitis for Stanford University, USA. Actively involved in research and academics, Dr. Jain has over 40 publications in peer-reviewed journals and has been speaker at various national and international conferences. She is also engaged in clinical trials and training of fellows. Additionally, she serves as the associated editor of the Delhi Journal of Ophthalmology. Over to you, Neha and Dr. Tania.
Hello and good evening, everybody.
Good evening, everyone. Thank you, Dr. Parthu, for such a opportunity to participate in a webinar. And I take the opportunity to welcome the panelists today. So we have with us Dr. Ratnam. She is the Chief of UVA Services at Arvind Eye Hospital, Madurai. Ma'am is one of the most respected names in uveitis and a favorite teacher, and well known for her work on the fast trial in uveitis. We also have Dr. Minusha with us, who is the head of Department of Medical Retina and Uveitis at Shankara Eye Hospital, Bangalore. She has done a lot of research work that has significantly contributed to our understanding of many uveitic conditions and their treatment. And we have Dr. Jyotirmay Biswas, who is the Director of Uveitis and Ophthalmic Pathology, Shankar Nethralaya, Chennai. So definitely needs no introduction. He's a well-known leader in the field of uveitis who has inspired a generation of clinicians. And I feel excited to introduce Dr. Soumyava Basu, who is the head of uveitis services across the LV Prasad campus, because he's my mentor. And he's well known for his expertise in the field of ocular tuberculosis. Very warm welcome to all the four panelists. And we are looking forward to having a very engaging and informative discussions today. So I hand over to Dr. Tanya to get started.
Right. Hello and good evening, everybody. I now request Dr. Lisa Sunny to please start with her presentation, and Dr. Ratnam will be her mentor.
Good evening, everyone. Is my screen visible?
No, not yet. Please share your screen.
Sorry, just a minute. Is it visible now?
Yes. Please go to the screen share, to the slide option. Yeah. Perfect.
Good evening, everyone. I'm Dr. Lisa Sunny, UVA Fellow at Aravind Eye Hospital, Madurai. And my discussant is Dr. S.R. Ratnam, who is our Chief of UVA Services at Aravind, Madurai. Today, our topic is IV cyclophosphamide to the rescue in a case of raging sympathetic ophthalmia. A 29-year-old lady came with complaints of defective vision in the right eye for one day, along with mild pain and associated floaters. She had undergone left eye scleral tear repair with pars plana vitrectomy and lensectomy 2 months prior to this, following a penetrating trauma with stone. On examination, the best corrected vision in her right eye was 6/18 parts and left eye was hand movements. The right eye anterior segment examination was unremarkable, and the left eye was aphakic with subconjunctival hemorrhage and a sutured scleral tear. On examination of the posterior segment, there was multiple serous detachments at the posterior pole as well as in the peripapillary area in the right eye. The left eye was a silicone oil-filled globe with a hyperemic disc and posterior pole detachments as well as laser marks seen in the periphery. On OCT, both the right eye as well as the left eye showed multiple serous detachments along with choroidal folds. B-scan showed right eye a serous detachment at the macula and RCS thickening of 2.39 millimeters, and the left eye was a silicone oil-filled globe. So we arrived at a diagnosis of both eye sympathetic ophthalmia and left eye aphakia post-scleral tear repair and pars plana vitrectomy. On fundus fluorescein angiography, in the right eye, as you can see, initially there are small hyperfluorescent pinpoint leaks, which increase in size and intensity in the later phases, along with pooling in the areas of serous detachments. And similar findings are also observed in the left eye, which is an oil-filled eye. On investigations, MAN2, HIV, TPHA, and VDR were all negative. ESR was 37 millimeters in the first hour, and CRP was 6.4 milligrams per liter. Complete blood count and liver function tests were within normal limits. So we started the patient on 500 milligrams of IV methylprednisolone in normal saline for the first 3 days, and also started her on 20 milligram methotrexate per week. 3 days later, the vision improved to 6/12, but the serous detachments persisted in the right eye as well as the left eye. And also the OCT showed serous detachments along with bacillary layer detachment. Therefore, the oral methotrexate was switched over to 100 milligram of oral cyclophosphamides and the steroids were continued. But to a disappointment, 4 days later, the right eye vision further dropped to 2/60 with a gross increase in serous detachments as can be evidenced in the picture. And also the OCT also showed persisting serous detachments in both the eyes. So we went ahead with another dose of 500 milligram of IV methylprednisolone, followed by 3 doses of intravenous cyclophosphamide, which were given 3 weeks apart. The cyclophosphamide was given at a dose of 600 milligram in normal saline along with mesna over 3 hours. And following the third dose, the serous detachments resolved completely in the right eye as well as in the left eye. Following completion of IV cyclophosphamide, the third dose, the patient was switched back to methotrexate, initially at 15 milligram, then stepped up to 20 milligrams per week, and the oral steroids were continued. The last follow-up was on 15th of April 2025, 10 months later, with right eye 6/6 vision, at present on methotrexate 20 milligrams per week, and omnacotil 5 milligram once in 2 days. So this is the final OCT with all the serous attachments resolved in the right eye. The left eye has a thinning of the retina, which is the operated eye. So if you see the timeline, this was the initial 3 days where we started with IV methylprednisolone for 3 days along with 20 milligram of methotrexate. On the 4th day, even though the vision improved, the serous detachments persisted. So we started cyclophosphamide 100 mg along with the oral steroids. 4 days later, again the vision dropped to 2/60. So we gave another dose of methylprednisolone and gave the first infusion of cyclophosphamide on the next day. 3 weeks later, we gave the second dose of cyclophosphamide infusion. The vision improved to 6/18. Another 3 weeks later, we gave the third dose of infusion. And later, it was converted back to 50 milligram of methotrexate. A month later, the best corrected vision was maintained at 6/9 on 20 milligram methotrexate and 7.5 milligram of omnacotil. 2 months later, the best correcting vision improved to 6/6 on 20 milligram of methotrexate and 7.5 milligram of omnacotyl. The last follow-up was 10 months later, that is in April 2025, and the patient is maintaining a 6/6 vision on 20 milligram methotrexate and 5 milligram omnacotyl once in 2 days. My questions to the panelists today are, what are the conditions where you would consider intravenous cyclophosphamide, and what has been your experience with the use of cyclophosphamide in terms of efficacy as well as adverse effects? Thank you. I'd like to invite Ratna Madam for further discussion on this.
Dr. Ratna?
Ma'am, you're not audible. No, ma'am, you're not audible, ma'am.
Ma'am, can you unmute?
Ma'am, please unmute.
Oh, she's unmuted because it's not showing the symbol there. But I think you have to use the option of use computer audio or something like that.
Backend team, can you help her?
Ma'am, can you join through your mobile device, ma'am? We can't hear you, ma'am.
So her Zoom, she says, has some issue. She's going to share her slide with me, so we will share her slide.
Okay, but yeah, her voice.
Volume also I have told her, sir.
Okay. Can madam, can you join from your mobile? Here, by the we'll play them.
Yes, sir. She's trying, sir. We'll just give her a minute.
Sure.
Yeah, meanwhile, when ma'am is trying to connect, can we have Dr. JB's opinion on the same?
So I have used cyclophosphamide in necrotizing scleritis, not in uveitis that much. Cyclophosphamide, I call it as a brahmastra, is that immunosuppressive agents as an immunosuppressive agent is the last resort. Here, that patient was given an 500 milligram IV methylprednisolone. I give 1 gram daily for 3 consecutive days. So 500 milligram is little less, and I don't use methotrexate for acute conditions like sympathetic ophthalmia and VKH. The reason is that they take little time to act. Mycophenolate mofetil is faster, so my choice would have been mycophenolate mofetil, and otherwise the case has been managed excellent ways, and IV cyclophosphamide did quite well with the treatment. I have treated VKH cases with IV cyclophosphamide, which did not respond to those days with azathioprine and cyclosporine. That time, mycophenolate mofetil was not there, but I used IV cyclophosphamide. The patient responded very well. I still remember that patient was from Andhra Pradesh and got back good vision of VKH case. So IV cyclophosphamide is a very good choice, and it causes a rapid resolution of inflammatory cells inflammatory mediators, and cause a resolution of inflammation. But I would keep it as my last resort.
Are you well connected now? I'm afraid we can't still hear you, ma'am. Yeah, Dr. JB, Dr. Anup wants to know that what are the thoughts of the panel in early introduction of biologics like adalimumab and infliximab?
In sympathetic ophthalmia and VKH, my experience is less. I just recently put 2 patients of sympathetic ophthalmia with adalimumab. One patient was really recalcitrant, and yesterday I saw him. He was doing so well, and everything got cleared up. But due to the subretinal fibrosis, vision did not improve that much. But media cleared so very well with the treatment with biologics. I think biologics has got a very good hope for recalcitrant sympathetic ophthalmia or VKH. So I have got limited use. 2 cases I have used sympathetic ophthalmia in biologic adalimumab. More experience is required.
I think there is some glitch.
Your thoughts, Dr. Manisha?
Yeah, in sympathetic ophthalmia, I don't have much experience with IV cyclophosphamide. I've not used. Usually they respond well, as Sir said, IVMP. Usually IVMP, I think they need in the first go itself IVMP. With introduction of IMT, these are the cases where you know that you have to introduce IMT and the steroids at the same time and with higher doses. I think somebody had asked
in
you the
case
role.
the
Yeah, I think someone has
Sorry,
asked you
ma'am.
yeah, I think somebody's asked on the role of local steroids. I would always place sympathetic ophthalmia since it's a one-eyed patient when you know the other eye is not functioning. So I think we should be very careful of introducing any local steroids because we're not very sure because the pressure can go up. So I think we should be a little cautious with local steroids in these cases.
In case it is not responding to the IVMP, and so what would be your next drug of choice?
As Sir said, usually it is MMF. Usually I put on mycophenolate mefetil and then the IV steroids. And if it doesn't function, then yes, we have to switch over to the next level as cyclophosphamide or the biologics. But I have not had such experience with the sympathetic ophthalmia so far. So usually they should respond with the IMT and the steroids. Sometimes recurrent, somebody introduced steroids, again they respond well.
And Dr. Basu's take on that?
There is can I make a comment? There is one option as giving a triple immunosuppression we have used in sympathetic ophthalmia. We published it where we have used cyclosporine, azathioprine, and prednisolone. Triple agent immunosuppression in serpiginous in sympathetic ophthalmia. Those are
There is some glitch with the retina presentation. After, I think, Dr. Basu's opinion, we can go to the next case and Madam can join later.
I'll just add that, cyclophosphamide is a way more efficacious drug than even the biologics in my limited experience whenever I got a chance to compare cyclophosphamide with biologic. I have never used it in VKH, but I know of others who have used it in patients of VKH, and whatever can be used in VKH can be used in sympathetic ophthalmia as well.
There are some papers from Europe in other earlier days where they have used cyclophosphamide for serpiginous choroiditis. Even AIMS has used serpiginous choroiditis cyclophosphamide. There are some papers.
What would you say on that, Dr. Basu?
I would not.
I'll reserve my comments on that.
I would not have used it now.
Yeah. So
I think let's go to the next case. I would like to invite Dr. Kelini Savlapurkar. She's from Shankara Eye Hospital, Bangalore, to present her case, and she would be mentored by Dr. Manisha.
Thank you, ma'am. Is my screen visible?
Yes, yes.
Okay. At the outset, I would like to thank UVIT Society of India and Partho sir for this opportunity. Going ahead with the case, we present a case of a 28-year-old male who came to us for a second opinion in June 2024. His chief complaints were diminution of vision in the left eye since 1 year. He was a known case of HLA-B51 positive, which we saw after reviewing his existing reports. And he was diagnosed occlusive retinal vasculitis with macular edema in the left eye elsewhere. And he had also received 2 intravitreal Avastin injections, and also sectoral laser was done in the left eye. He was a known steroid responder and recently diagnosed diabetes. His present medication history, when he presented to us, he was on brimonidine and dorzolamide timolol eye drops in the left eye. He was on low dose of oral steroid, 5 milligrams, which he had been gradually tapering since almost a year. And he was on medications for diabetes. In the past, he had received azathioprine for about 7 months, following which he was switched to adalimumab, but he had discontinued it on his own after 2 months of taking the injection because of white patches which he developed on the trunk post-injection. His uveitic workup was unremarkable and the HRCT chest showed enlarged subcentric nodes. On examination, his vision was 6.6 N6 in the right eye, 6.12 N8 in the left eye. His intraocular pressure was on the higher side of normal. Right eye anterior segment was unremarkable, but left eye showed small, fine, non-granulomatous KPs along with +1 cells and posterior synechiae. On fundus examination in the right eye, there was segmental vasculitis, which was noted in the inferonasal quadrant. And in the left eye, there was mild vitritis with flame-shaped hemorrhages close to the disc. And the superotemporal vein was dilated and tortuous with peripheral vascular sheathing. The foveal reflex was dull, and sectoral laser marks were noted in the superotemporal quadrant. As he was already on oral steroids, we continued him on the same and referred him to the rheumatologist to start.
I am opening the input volume is slow.
Ma'am, you're audible now. Dr. Kelani is presenting her next case for now. Yeah. Please go ahead. Yeah.
Yes, ma'am. Thank you. So we referred him to the rheumatologist to start on immunosuppressives. Unfortunately, he was lost to follow-up for 6 weeks. And when he returned with a diminution of vision in the right eye this time of 3 days duration. At this point, he was taking adalimumab injections, but had missed his previous dose. And he was still on 5 milligram of oral steroids, and he had started on methotrexate 15 milligram per week for 1 month. In the right eye, though his vision was 6.6 N6, new lesions were noted in the superotemporal quadrant with perivascular cuffing and adjacent flame-shaped hemorrhages, and there were retinitis lesions which were close to the fovea. And in view of the progressing lesions, we stepped up the steroids to 70 milligrams per day. Again, after this, he was lost to follow-up, and when he returned, he was continuing the tapering of the oral steroids at 10 milligram per week, and the adalimumab and folitrax was continued. The lesions were noted to be resolving. However, there was a new frond of neovascularization noted inferonasally in the right eye. And a month later, he also developed cystoid macular edema in the right eye. Another month later, he presented with worsening of vision in both the eyes. His vision in the right eye dropped to 6.12 N8, left eye 6.36 N24. And in the right eye, subhyaloid hemorrhage along with vitreous hemorrhage was noted, and similar findings were also noted in the left eye. We went ahead with an ad laser for both the eyes and advised a propped up position. However, 1 month post-ad laser, in both the eyes, there was relentless progression with new NVE lesions approaching the fovea. This is the left eye. And another, this is the OCT of the right eye at that visit, showing a neurosensory detachment at the fovea. So in view of lesions which were threatening the fovea, we planned for an intravitreal anti-VEGF injection in the right eye. However, he was not willing for the anti-VEGF injection. So following the ad laser, we had no choice but to observe him. And 2 months later, however, there was progression of the traction, as you can see in this OCT image, because of which we went ahead with a preoperative anti-VEGF, followed 3 days later by a band buckle and a vitrectomy. This is the post-op image at 1 month post-vitrectomy, showing a silicone oil-filled eye and stable retina. The vision was maintained at 612 N10 in the right eye, and left eye was 66 N6 after resolution of the vitreous hemorrhage. And this is the latest follow-up at 2 months post-op, which was noted a few days back, where he is maintaining stable retina with 6/9 N6 vision in the right eye and 6/6 N6 vision in the left eye. I invite my mentor, Dr. Minija ma'am, to take over the discussion of this case.
Can I go ahead, Dr. Tanya?
Yes, ma'am. Yes, ma'am, please.
Yeah, thank you, Dr. Kelini. I think the importance of this case is because you know that when you look at the images, Kelini, you can just go back to the previous slide. So if you look at the images, you can see with the steroids, the inflammation, the vascular cuffing was reducing, but the issue was a neovascularization. It was very aggressive. And I think you can just show the image where you have the, Kelini, can you just show that image where you have the neovascular front and then yeah. Yeah, so if you look at this was a time which fits, I think it's very important as a medical retina person, you know, because whenever we see neovascularization, we inject. But the thing is, if you inject in this patient, the macula is going to go off and, you know, he can drop in vision. So it's very important for us to know when we have to hand over the case to the, you know, VR surgeon so they take it for surgery. So this patient, we had to, you know, do the surgical intervention at the right time. Otherwise, he can lose his vision. The second thing was this patient was non-compliant. See, sometimes when we see the inflammation and not responding, you see the recurrence. So as we always say in uveitis, history taking is so important. So he never used to tell us that. We never used to think that why the inflammation is not coming down. Then he told us that he was not taking the medication. So before we jump in and putting too many immunosuppressants, I think history taking is so important to understand. Is the patient compliant? Because all these drugs are so expensive, so some of them may not take the drug. So later on, when he was compliant, we saw that there is resolution of the hemorrhage. And if you look at the images, there is no perivascular cuffings. It's all cleared, but just the neovascularization, which was not settling down. So that was the reason we had to take up this patient for surgery. Otherwise, he would have gone for a TRD and a CRD and his vision would have dropped. The second thing is, yes, we did a belt buckle because the dissection of the peripheral dissection of the hyaloid proliferation is difficult and the lens is a clear lens. So that's the reason he put a buckle, and silicone oil was introduced so that in case it has a break also, it doesn't happen. So that's the reason Dr. Mahesh wanted to put an oil inside, and we're planning to remove it in 3 months' time. So the second here is always the Behçet's vasculitis are very aggressive. So I think we have to do an extensive laser because it cannot be a normal what you do a sectoral laser, because you see looking at the neovascularization, we have to decide what kind of laser we need to do, just a sectoral or an extensive laser. So that is also very important here. Now, coming to, and of course, I think this is a case which all of us know that Behçet's vasculitis is something we have to introduce immunosuppressive at the earliest. But I think even the biologics does very well for this kind of aggressive cases. We have to add even biologics in the first go itself. This patient was added initially itself. I think he was being seen at CMC well earlier. Now, coming to vasculitis, can you just go back to the next slides, Kelly? So I think whenever any of us see a case of vasculitis, it's very important to differentiate an inflammatory and a non-inflammatory, because sometimes we have seen cases coming diagnosed as vasculitis, but it could be non-inflammatory. So and we are using the word also, we should not use sheathing, because sheathing is actually non-inflammatory. And whenever you have a perivascular cuffing, it's considered as inflammatory. And how do you differentiate is always by FFA, which shows a leakage and staining of the vessel wall. And there are some, of course, by looking at the clinical features, we can find out what kind of vasculitis should be before we investigate the patient. Of course, I think Dr. Basu's article, which he had shared with us in the USA, that is very informative article, where we know that what are the features of TB vasculitis. So next slide, Kim. So you know that, subvascular lesion, whenever you have these lesions along the blood vessels, we know that it could be TB vasculitis. Next one. Then you have the confluent perivascular sheathing with CNP areas, we know occlusive vasculitis, that again gives a clue to a clinical diagnosis. Of course, the focal vascular torch. So these are the features which was mentioned in the article. And of course, it gives a clue it could be TB retinal vasculitis. The other common condition which we come across is sarcoidosis. So here, along with the vasculitis, you should always look the associated clinical signs whenever see vasculitis. So you might have granulomas. The vitreous involvement is more severe in case, sometimes in sarcoidosis, you have the snowballs and the snow banking. And they are more of segmental or a vascular sheathing, which the FFA clinches the diagnosis, and it is always non-occlusive vasculitis. The other one, which we normally come, as already told, Behçet's, they have intraretinal infiltrates and adjacent hemorrhages, occlusive retinal vasculitis, and even full thickness retinal. So these are characteristic of Behçet's vasculitis. Other condition, vasculitis infective, always the sclerosis arteriolitis, but they say that whenever you have this periarterial plaques, we should always suspect, infectious etiology. So the most, I think, important investigation along with clinical is your fundus fluorescein angiography. Why is it important is because I think it gives us a clue what kind of leakage, the intensity of leakage, because that gives us a clue what is the management. Because if your leakage, something clinically you don't find what is the level of the inflammation, but FFA will definitely give us a clue. So you have extensive leakage, we know that we have to go. The treatment should be aggressive. We have to introduce steroids at higher dose, IMT, or sometimes even the biologic. So I think every case of vasculitis, we need to do an FFA. And of course, if in case we are planning for a laser, to know the level of where do we do the laser, that gives us a guidance for the laser treatment. So as I said already, I think FFA is important in vasculitis. It helps us in management and treatment also. What kind of management? I'm sure if anyone would like to add, I know Dr. Biswasa, Madam, Dr. Basu, Ratina, Madam. I think, Kellen, you can stop sharing the screen.
Yes, ma'am.
Thank you, ma'am. Thank you for this case. Especially it is very difficult to manage, very well managed case. And ma'am, so what we highlight, especially with your case, is the importance of starting biologics, the importance of compliance, and a very well done laser, and taking a best decision for retina surgery at the right time. So we have a few questions from the panelists, from the attendees. How to differentiate a CMV retinitis from Behçet's vasculitis with full thickness retinal infiltrates?
I think in the CMV retinitis, you typical, it's along those, I think more on the posterior pole. Here in other things, you find it along most of the other vessels are also seen. And I think it's more extensive, like what you don't find in this. And I think the retinal infiltrate is a little difficult to differentiate between the two. And I think one more thing is in Behçet's, it's very smaller in size. It's not along it's more extensive in CMV retinitis. Whereas if you see it's along the blood vessels in case of Behçet's. Whereas if you see in a CMV retinitis, the area of involvement is more compared to a Behçet's. This here it is all along the blood vessels.
Okay.
Whereas in CMV, you don't find it along the blood vessels.
I will switch off the phone and I have to talk to check.
All right. JB sir, any thoughts on?
Actually, the CMV retinitis is in the immunocompetent patients. You will not see CMV retinitis. It's immunocompromised either by HIV or any other immunosuppression, like immunosuppressive drugs, malignancy, lymphoma, etc. So that's one of the things history or clinical examination itself will tell us that it's not CMV retinitis or Behçet's disease. Capillary farning is a very characteristics of Behçet's disease. CMV retinitis will not get the capillary farning. And CMV retinitis having dry granular appearance retinitis. It can happen in the posterior pole predominantly, but can be seen in the periphery also. We have seen in HIV era a lot of peripheral CMV retinitis cases. But occlusive vasculitis is characteristics of Behçet's disease or more common in that retinal infiltrate we see in Behçet's disease. I think
Am I audible now?
Yes, ma'am. Yes, ma'am.
very different.
Okay, I'm very happy that at least I'm audible. Can you give the discussion now for the first case?
Yes,
Or
ma'am.
you have still questions?
We have just one more question from the
Yeah,
audience.
finish
We
that.
discuss
Finish that. I'm
and then
sorry.
we take over
I'm
the
sorry.
discussion for
Yeah,
the
yeah.
first.
Please
Uh,
proceed.
Another question is is the experience of the panelists about the predictive value of HLA-B51 and pathogy tests in the diagnosis of Behçet's disease?
Can I take this one?
I couldn't consider it as a diagnostic test for Behçet's.
Yeah. So just to clarify a little bit more, HLA-B51 is not included in the diagnostic criteria of any of the diagnostic criteria for Behçet's. We need to remember that HLA-B51 is positive in up to 12% of the normal population in Indian patients. And some labs do only HLA-B5. B5 is positive in up to 30% of the normal Indian population. So that's the problem. The other side of it is that up to 40% of Behçet's patients are B51 negative. So either ways, B51 is not going to lead you to a diagnosis. The only way to make that is oral and genital ulcers. The other question was about pathogy test. My colleague, Dr. Anup Kelgaonkar at Bhubaneswar has much more experience. He does it regularly. But as I have learned from him, it's more useful if you do it in patients who have skin manifestations of Behçet's. Those who do not have, usually the pathogy test is not useful. And anyways, that again is also not part of the diagnostic criteria of Behçet's disease.
I would
There
also the experience of panelists about golimumab. Do we think that's a drug which is more efficacious and better than adalimumab? Any experiences?
I don't think so. And I have got just limited literature. I have used golimumab in 1 or 2 cases. Adalimumab is much better and much efficient than golimumab. I have got 2 cases. They responded well, but in general, the experience of golimumab is much less.
I've used in a case of a pediatric, I think one of the patients is on pediatric JI. I mean, on JI patient, no, is on golimumab. Adult, I'm not.
Okay, so we can go for the discussion of the first case, Ratna ma'am, and then we move on to the third case.
Thank you. Am I audible?
Yes, ma'am.
Yes, ma'am.
And is my slides visible?
Yes, we can see this.
Ma'am, is this the one which has primary
That
healthcare?
56-year-old
Yes,
male
yes,
patient.
yes,
Yeah.
yes, it's
Okay.
visible.
Thank you so much. I'm very sorry for some technical reason it was not opening before. I'm going to give you a very interesting case of accountant working in primary health center. He was 56 years old male patient. He had chronic cough and smear was 4+ positive for tuberculosis. And he also had uncontrolled diabetes. So he was treated fully by 9 months ATT and he was absolutely all right. By the time, in one year time, after the tuberculosis happened in 2017, and he was fully treated. 2018, he had left ear ache, and it was suspected as bacterial otitis media, and left ear surgery was done, but it was a failure, and he lost his hearing capacity. And soon after 1 month, he again developed a severe cough and suspected as a relapsed TB. ATT was started again, but he was not improving at all. Then after 1 month, he developed severe headache, extremely severe headache, and radiological diagnosis was probably sphenoidal sinusitis due to fungus. So FES surgery was done and biopsy was taken, and biopsy was negative for fungus. So in summary, he also had scleritis. After 1 month of all these problems, he came to us. So to do a summary, here is a patient with severe scleritis, a suspected fungal sphenoidal sinusitis, a suspected bacterial otitis media, suspected relapsed TB. You just remove this fungal word, bacterial word, and TB word. You just see a scleritis patient having these sinusitis, otitis, and pulmonary problem. You may come to some conclusion that it is a different entity. You are absolutely right, because the scleritis progressed so fast, and it was a scleral melt and conjunctival melt. The sclera got exposed like this. By this time, you will know the diagnosis was vaginous granulomatosis with the sinusitis, with the ear problem and pulmonary problem. His kidney was spared. So by this time, it was mistakenly thought as fungal sphenoidal sinusitis, bacterial otitis media, and relapsed tuberculosis. So we did ANCA, and it was positive. His ESR was very high, CRP was very high. At this time, we wanted to get a rheumatologist opinion also, because everybody is thinking of 3 different infections. We are thinking of an autoimmune disease, and our immunologist confirmed the diagnosis of vaginous granulomatosis, and he was willing to give rituximab. 500 milligram, 4 cycles were given. Patient improved so well. See, the epithelialization has come, and patient improved absolutely all right. Unfortunately, after 1 year, he had again the relapse, and he started having scleral pain. At this point of time, he was not willing to spend for rituximab. Then we switched over to cyclophosphamide. After cyclophosphamide, this is his picture. He not only scleritis resolved, he went into remission, and for past 3 years, every year we are seeing this patient, and he is still on remission. So what I am going to tell you now is, cyclophosphamide we use a lot, especially in patients who cannot afford for adalimumab. And it is a wonderful drug. I used to say that in our puja room, we have to have the scientist photograph who invented cyclophosphamide. I'll show you some of the data from our clinic. In past 5 years, we have treated 69 patients with cyclophosphamide. Of them, 40 patients had good complaints and follow-up. So the 40 patients will be shown here. Many of the VKH patients who are resistant to methotrexate or mycophenolate mefetyl or azathioprine, we go to cyclophosphamide, especially when they are not able to pay for their adalimumab. And unfortunately, our patient group has very low socioeconomic group as well. So we have to find some alternative. So cyclophosphamide works so well in these patients. And our second group, majority of group, as Dr. Biswas sir mentioned, scleritis, and few patients Behçet's and intermediate uveitis and pan-uveitis, and 2 of our patients were sympathetic ophthalmia. And this failed treatment was oral steroids and azathioprine, oral steroid and methotrexate. In some patients, it is methotrexate and azathioprine, and some patients, it is all 3 drugs, methotrexate, MMF, azathioprine failed. The last patient is the one which I showed you now, the oral steroid and rituximab. He failed in rituximab also, but he went into remission with cyclophosphamide. The one difference between adalimumab and rituximab is, adalimumab and cyclophosphamide is, all these newer biological, when we stop, the disease is likely to come back. But when the remission is because of cyclophosphamide, the complete remission happens. That is the good news. Or at least they go into stable state. I'll show you that picture also. And most of the time, these patients are on treatment for 1 year to 2 years. Very few patients will need 3 to 5 years in a maintenance dose. As far as response is concerned, remission, whoever has gone into remission, 15 patients out of 20 have gone into total remission. They do not need any other immunosuppressive for at least 3 to 4 years. The stable patients are stable just with methotrexate. They were controlled with cyclophosphamide, then methotrexate. They needed either low-dose oral steroid or low-dose methotrexate so that they are stable. And recurrences do occurred in 9 patients. And those patients, we raised the funds to give adalimumab treatment, but it was not sustainable. And when we see the response, as Dr. Biswas sir mentioned, scleritis, cyclophosphamide works wonderfully. And at least some patients of BKH with very, very resistant for other drugs, they do become remission in at least 5 patients went into remission and 10 patients were on stable state. Only few patients were not responding. So the one take-home message is, as we thought, it is not a very dangerous drug. MUST trial has clearly shown that it is not causing any cancer in American patients. In our patient, transient leukopenia was seen in 8 patients, and hematuria in 2 patients, and nail discoloration in 2 patients. And we really find cyclophosphamide as a wonderful drug when the patient is not able to afford for new biological. Thank you. If you have any questions, I will be happy to answer.
Thank you, ma'am. This data is amazing. Any other thoughts from the other panelists about? Yes, sir. JB, sir.
Yes, sir.
So I'm little cautious about cyclophosphamide because this bone marrow toxicity is quite. Instead of every 4 weeks blood count checkup, I check the blood count every 2 weeks in cyclophosphamide because they produce neutropenia much faster.
Yes, sir. We are very, very cautious with these patients, sir.
Ma'am, I have a question for you. Are you getting oral endocrine easily because it's not available very easily?
Cyclophosphamide?
Yeah.
Yeah, it is available, both oral as well as IV, very much available.
IV is available. IV is very much there, but oral...
oral is also available.
Okay.
I use oral often, quite often.
Ma'am, I have a question. How do you taper if you want, when do you want to stop it? How do you stop the cyclophosphamide? Do you taper or just?
I taper. From 100 milligram, I go down to 50 and I keep the patient on 50 for at least 3 to 6 months. Then only I stop. And when I stop, if the inflammation is still lingering, then I continue with oral steroid and methotrexate. Originally, the patients who were resistant to methotrexate, after cyclophosphamide, they work very well with the methotrexate.
Now, when introducing cyclophosphamide, is it like you follow the IV and then oral, or you start sometime?
When it is very severe, like vision loss, as Lisa's case, we give IV. Otherwise, we start with oral only. Most of the patients do very well with oral. Just 100 milligram, it comes as a 50 milligram tablets. 2 tablets, 100 milligram tablets in the morning, only in the morning, with 3 liters of water before 1 o'clock. So I tell them very, very clearly. Then we follow up and we call them over phone to see whether they are taking enough water. But fortunately, none of the patient went into bone marrow depression. There was a very transient leukopenia, then it reversed with stoppage of cyclophosphamide. And in my opinion, cyclophosphamide in poor patients, it is a wonderful drug.
The dose remains same over 6 months.
Over 6 months, 100 milligram for 6 months, then 50 milligram for 6 more months.
All right, along with methotrexate.
No, after stopping cyclophosphamide, I continue with methotrexate.
Okay. All right.
What is the alarming dose of alarming level of leukopenia for you when you stop cyclophosphamide?
No, 3000. I actually in Proctor Foundation where I was trained, they bring down below 3000 white blood cell counts, and that was their target. But I never do that. I just give 100 milligram and 50 milligram. I closely follow up. When they reach 3000, I either reduce the dose of cyclophosphamide or taper it. Because our scenario is the environmental contamination is so much, I do not purposely bring them down below 3. But there, they bring down till 2000 and they are very comfortable because they don't get opportunistic infection that often. But I keep above 3000. None of them went into 2000 and all. They just came down to 3000 and I took the steps.
Ma'am, there's a question. Is the dose according to the weight or blanket 100 mg?
Yeah, actually, all the textbook mentioned surface area, and we calculated, and there was one publication which gave the definitive thing. In adults, it is 1 to 2 gram, 1 to 2 per kilogram body weight. And that is why we give 100 milligram every patient. And then we checked with surface area calculation also. It comes around that only. 1 to 2 milligram per kg body weight.
All right. Thank you. Thank you, ma'am. We will go on to the third case. Dr. Rakshita, please share your slides. And Dr. Rakshita will be mentored by JB sir.
Hi, good evening. Is my screen visible?
No. Yeah, now it is. Please go to the slide share mode.
Good evening to all. Thank you, UVIT Society of India, for this opportunity. So I'll be presenting a case of a 30-year-old male who presented to us with complaint of floaters in his left eye for 3 months and painless blurring of vision in his left eye for 2 months. On examination, the best corrected visual acuity in both his eyes was 6/6 and N6, and the anterior segment examination revealed cells in anterior vitreous space in both his eyes. On fundus examination, the right eye media was clear, disc and macula was normal, and the background retina was also normal. While the left eye showed dense vitritis, disc was hazily seen, and retina details were hazy. Optical coherence tomography of both the eyes showed maintained foveal contour. Thus, with the diagnosis of left eye intermediate uveitis, the patient was further investigated. His tuberculin sensitivity test IGRA were negative, serum angiotensin converting enzyme and HRCT test were within normal limits, and serology for syphilis was negative. He was then initiated on treatment with oral steroids and mycophenolate mofetil for 2 months. So at his 2 months follow-up, there was still persistence of floaters and blurring of vision. On examination, he also had both eyes vitritis at this visit. So considering the non-response to treatment, his treatment was escalated to injection adalimumab 40 milligrams subcutaneous biweekly. At 4 months follow-up, there was still persistence of his symptoms and his visual acuity dropped down to 6/12, while the foveal contour was maintained on OCT. So here we plan for left eye diagnostic and therapeutic vitrectomy to find out the underlying etiology. On histopathology of his vitreous specimen, there were atypical lymphoid cells with hyperchromatic nuclei, scanty cytoplasm, and moderate nuclear pleomorphism. Immunohistochemistry of these atypical cells was positive for CD20, BCL2, PAX5, and MUM1. CD3 was negative, thus supporting the diagnosis of B-cell lymphoma. So we diagnosed the patient as left eye primary vitreoretinal lymphoma, and to rule out the systemic involvement, he underwent whole body PET scan and MRI brain, which were within normal limits. So at 1 month follow-up post vitrectomy in left eye, we also planned for right eye vitrectomy. So the histopathology specimen of its right eye also confirmed the presence of atypical lymphoid cells, which were positive for CD20, MUM1, PX5, and BCL2. The specimen was also positive for MYD-ated L265P mutation. He was then referred to oncologist, and in view of bilateral lymphoma, he was advised high-dose intravenous methotrexate, rituximab, and oral temozolomide. So to summarize, a young male who presented to us with complaint of floaters was treated as intermediate uveitis. He was not responding to anti-inflammatory treatment, underwent diagnostic vitrectomy for search of underlying etiology, and was diagnosed primary vitreoretinal lymphoma with no systemic involvement. So few points to ponder in these case was PVRL being most common in elderly age, when to suspect masquerade in young age. Role of vitrectomy in such cases, does it have any therapeutic importance, and when to stop immunosuppressive before doing vitrectomy? Difficulties in tissue diagnosis like need of expertise and need to transport early transportation of the specimen, and approach to treatment for a standalone intraocular lymphoma with no systemic involvement. So here I hand over the further discussion to Dr. JB sir. Thank you.
Okay, sir.
This case is a very interesting and challenging case. I just went into a stepwise approach, and I did not think that lymphoma at the first place, though I've seen, because the age of the patient was 30 years only. The lymphoma, primary vitreoretinal lymphoma, occurs in ages like 50 years of age or so, though I have seen one case of vitreoretinal lymphoma in a 30 years old patient about almost 25 to 30 years back. That patient was a sketch pen owner and used to come, and every time I used to give posterior subtenon steroid injection and it becomes all right. And then again it comes back with the vitritis. And later on, the patient developed CNS problem, and MRI showed, that day MRI was not there. CT scan showed that lymphoma lesion. There's a way back. There's only one case in my history, in my experience. I had intermediate uveitis presenting as a lymphoma. So this case is the primary vitreoretinal lymphoma is uveal lymphoma is a primary low-grade lymphoma. Secondary, from a systemic high-grade lymphoma, it can involve the iris, ciliary body, and choroid. And in the when you call vitreoretinal lymphoma, it is from vitreous body, retina, or optic nerve. And this can be PVRL, that is a primary vitreoretinal lymphoma, or ocular involvement of primary central nervous system lymphoma. And it can be secondary from a systemic diffuse bulbar cell lymphoma. So the diagnosis is often present. Slit lump examinations, that they don't present to the KPs usually, but fundus examinations will be seeing that vitritis. Angiography is that sometimes gives a appearance of lesions, is that honeycomb-like appearance, and the diagnosis is often based on the strong suspicion of a muscular syndrome. And you need to do a cytology, immunohistochemistry, cytokines, and molecular biology. And the treatment is that 50 to 90% of the patients within 30 months develop serious lymphoma. So, and MRI is a very good, important investigations to do that, to rule out lymphoma. And this patients is that therapeutic options is a local treatment, intravitreal chemotherapy, methotrexate, or rituximab. We give methotrexate mainly, and ocular radiotherapy when there is a extensive lymphoma is there. Systemic treatment is that methotrexate-based chemotherapy, intensive chemotherapy, or even autologous stem cell transplantation can be given. And there is medications like temozolomide, or targeted therapy like ibrutinib, lenalidomide, and in extreme cases, whole brain radiotherapy can be given. So the question is there how to differentiate lymphoma, primary vitreoretinal lymphoma, from uveitis. that ocular injection like circumcorneal congestions would be very much absent in case of PVRL, whereas the uveitis it will be there. Anterior chamber inflammation, you will be mainly will be seeing the vitreous cells. The vitreous cells, type of the vitreous cells is often coarse vitreous cells. Then the fine vitreous cells which is seen in intermediate uveitis, and keratic precipitate not present, and uveitis will be seeing some kind of keratic precipitate most of the times. Synechiae will be in a case of primary vitreous lymphoma is almost nil, and in uveitis is you will be seeing sometimes synechiae formation. Vitreous is cellular in case of PVRL, and cellular and albuminous flare will be there in case of vitritis. So retinal, the subretinal or retinal infiltrate will be seen in case of primary vitreoretinal lymphoma, and that's one pattern is seen in case of primary vitreoretinal lymphoma. And in case of uveitis, we get that all the features like vasculitis, retinitis, etc. Macular edema is typically absent in case of primary vitreoretinal lymphoma. OCT is very useful, and you can see the subretinal infiltrate, sub-RP infiltrate is seen over the region, and in case of uveitis, you will get the macular edema and subretinal fluid. Fluorescent angiogram, hyperfluorescent spots in active lesions, window defects, scar, retinal pigment epithelial disturbances corresponding to the leopard skin presentation pattern. So, and vasculitis, etc., will be cystoid macular edema, inflammatory capillopathy, it will be seen in case of uveitis. So, how to diagnose? So, even if we make a clinical diagnosis, you need to make a biopsy-proven diagnosis in case of vitreoretinal lymphoma. So, you will need to do a vitreous biopsy, and the specimen should be subjected for histopathology and immunohistochemistry and MYD88 mutations. One can do fine needle aspiration biopsy when there is a choroidal infiltrate is there. We have done some cases, and chorioretinal biopsy is that requires a lot of dexterity, where you can take a small bit of chorioretinal tissue and can do that immunohistochemistry and histopathology of this tissue. So what is one important message I wanted to give you, that lymphoma cells are very fragile. They don't last for more than an hour or so, they become degenerated. And degenerated cells are very difficult as a pathologist. It is very difficult to differentiate from inflammation, like, polymorphic nuclear leukocytes often degraded and they produce, and this degenerated lymphocytes is very difficult to differentiate from malignant lymphoma cells. So within half an hour, specimen should be taken, and while doing the vitrectomy, the low cutting rate should be kept, and so that the specimens should not get degraded or lymphoma cells doesn't get damaged. And even the cassette fluid is also very useful to find few abnormal cells. So these are the three different patterns of lymphoma. Then one is the subretinal infiltrate, leopard skin-like appearance, or focal focal choroidal infiltrate, and third, which our patient presented with the vitritis, recalcitrant vitritis. So I thought that the patient is probably having a recalcitrant intermediate uveitis and treated with the immunosuppressive agents and then biologics. And then when you found it's not responding and the vitritis is increasing in size, I thought that it's important to rule out lymphoma in this case. Also, sometimes recalcitrant intermediate uveitis can respond to vitrectomy. You can get cleared up with the surgical procedures. So a little bit about the histopathology. And what are the features which you see in the pathologies? As a pathologist, I see that there's scanty basophilic cytoplasm, increased nuclear cytoplasmic ratio. And then if you look at the nucleus, there is a hypersegmented nuclei with various shapes and sizes. And the coarse chromatin pattern will be seen, and that stains which are used in that hematoxylin stain is good. But if you want to see nuclei better, you can do the MCG stain. And CD20 is the B cell marker, which is used in these cases. And you can see that lower picture is not from this case. Is the CD20 cells was positive in the lower marker, and Ki67 showed a high ratio of proliferative index was seen in such cases. And another thing is that now has come, which we have got the facility to do, that was the MYDL 265 mutations, and this is positive is almost over 80% of the cases. IL-10, IL-6 ratio is also a good marker for diagnosis. IL-10 is elevated in case of lymphoma, while the intraocular inflammation IL-6 ratio will be elevated. But nothing like looking at the cells. Instead of cytokines profile, is looking at the cells, abnormal cells will give you a diagnosis. Based on the IL-10 IL-6 ratio, the radiologist or the oncologist will not give the treatment for such patients because these drugs are a little heavy and toxic. So we need to have a tissue diagnosis, and that can be done by cytopathology only and immunohistochemistry. This was a paper published by us, MYDL265 mutations in intraocular lymphoma, which was used in this case. And we found the 88.9% sensitivity and specificity of 91%. So it's not foolproof, but it's quite effective. So Vitreous sample procedures I've told already, and I'm not going into the details of it. And 3 steps: one is the cytopathology, then is the immunohistochemistry, and then is the IL-10, IL-6 ratio, and MYDL265 mutations. So points to note: a definite PVRL diagnosis can be made by the cytologic detection of malignant lymphoid cells with monomorphic, monotypic, and or clonal characteristics like B cell type. This process is a challenge when there is a low cellularity or poor sample quality, like you have transported the specimens from one center to another by one, and then it gets degraded and it becomes very challenging to the pathology. There is a solution called HOPE solution, HOPE fixative, that can keep the cells active for some time, but this is not that the best solution. Best is to do that immediate transfer of the vitreous fluid to the laboratory and make a good pathologist to see immediately under hematoxylin stain or MCG stains. And this is a diagnosis which is very crucial. Any patient who is not responding to the immunosuppressive agents or biologics, 2 months up is the maximum period you should wait and go for a vitreous biopsy. And if your center doesn't have that immunohistochemistry or cytopathologic expert, I think this is the type of the cases which should be referred. Any questions?
Thank you, sir, for such a crisp talk. And to summarize, I think you gave a message clear that if for 2 months the case is not responding, then we must go for a diagnostic vitrectomy. And we have to do it at a low cut rate and get an immediate pathology done if we really want the diagnosis. But I'm afraid at a lot of centers, we are suspecting and we cannot even refer. We don't have those kind of centers. So we really don't have any media in which we can add the samples and transport it to the diagnostic labs.
There is a called HOPE fixative, HOPE, HOPE fixative, which can be used for transferring this kind of samples. But that's not the very ideal situations. Better to, this is a limited number of patients only, and better to send these patients to a facility where this can be handled properly. This is only one narrow group of patients of intermediate uveitis where he needs referral to a heart center.
I agree with Dr. Neha. Sir, it is very difficult to have a good pathologist like you, sir.
No.
Yes, ma'am. I think that's very important because when most of the time when we send the sample, we don't get the correct results. So as madam said, I
So
think
even that
pathologist is very important.
in abroad also they miss that diagnosis. Sometimes 2 or 3 times vitrectomy is required. Vitreous biopsy is required to come to a diagnosis.
So the next question that I had, sir, was when we know that lymphoma is primarily in the eye, would you like to go for local treatment?
Yeah. That intermittent methotrexate has been done, but almost always rule out that CNS lymphoma and periodically do the MRI every 6 months.
Yeah, screening should be done every 6 months. But why did we go for systemic treatment in this one when we had it in?
Because he has got a bilateral primary vitreoretinal lymphoma. And, yeah. And it has got KY67 range was very aggressive type of primary vitreoretinal lymphoma. Within 2 weeks' time, he developed lymphoma in the other eye.
Yeah. So
That
there's
also showed lymphoma. So
Yeah,
the
so
oncologist was the best person to decide, and they decided against the intravitreal chemotherapy because it's a bilateral involvement and aggressive.
So even if we have treated with systemic treatment, we still need to every 6 monthly.
Yeah, take up that.
The lifetime.
Yeah. MRI brain. It's not a very good disease. Yeah, to be on the safest, to be honest. So up to 5 years, maybe the patient can prolong. And
Right. So there is an audience question which asks, is there any role of autofluorescence in these kind of cases?
yeah, this is the leopard skin-like appearance in the early stages. Autofluorescence is quite helpful, and it will get typical pattern of mottled autofluorescence.
And what about sub-RP deposits on OCT in case of PVRL?
Yeah, that's also a good example and good OCT. Nowadays, the OCT is quite handy in detection of early vitreoretinal lymphoma.
They also want when we were suspecting a diagnosis of intermediate uveitis, you started off with MMF.
Yes.
Routinely do that.
I routinely do that because I find that over the years that is intermediate uveitis is not a short-term disease. It's a prolonged chronic disease. So they need to keep on steroid for a very long time. I would prefer to give that immunosuppressive agents and steroid in a low dosage to minimize the side effect of the steroids. So immunosuppressives after some time is become very well tolerated in majority of the patients. They do very well. And immunosuppressive agents, intermediate uveitis treatment for 2 to 3 months is not good enough. For 6 months to 1 year or more than a year you may require. And unilateral cases become bilateral ultimately.
So with MMF, have you noticed any unexplained weight loss in the patients ever? Like when the patient is on 1.5, 2 years of therapy of MMF?
No, but I have seen that they develop herpetic viral skin lesions. That I've seen about 3-4 cases. So one of the things is that they can get, and they develop a lot of gastric problems.
So other panelists, any would like to share the experience on PVRL?
So, Neha, can I say?
Yes, sir.
Yeah. So, first of all, the images that were shown in the presentation, they were excellent. The quality of so, like ma'am said, only sir could do that kind of images. So we must appreciate that. I had a comment not so much on PVRL, but on the use of adalimumab in intermediate uveitis, especially when you're not aware of the cause, because all the tests that were done for intermediate were negative. Because some of these cases of intermediate uveitis could be multiple sclerosis. especially when it is presenting with granulomatous anteuveitis or a retinal vasculitis, which is above the horizontal meridian. So these are multiple sclerosis, and that would be exacerbated if we give them adalimumab. So, although it is still non-infectious uveitis, we should be a little cautious about using adalimumab in these patients.
I agree with you. Intermediate uveitis is one of the manifestations of multiple sclerosis. But fortunately, it's not that very common in India.
Dr. Manisha, any thoughts? Dr. Ratnam? Yeah. So there's another question, sir, that if we treat the PVL patients, is there a percentage in which they go into complete remission and the CNS involvement really doesn't happen? Have you seen it?
No. Actually, is that I don't have any patients surviving more than 5 years in my record. So it can prolong the life. 5 to maybe that with the treatment, newer treatment, it might be may prolong to 5 to 10 years, but more than that, my experience is more than 5 years. No patient is there. Ultimately, they develop CNS lymphoma, and that is quite fatal. It's not the best disease which you can have.
So we would now move to the next case, and I would like to invite Dr. Tanya for her presentation, and she would be mentored by Dr. Soumya Babasu. Dr. Tanya Sagar?
Ma'am, am I audible?
Yes, yes, you're audible. Please share your screen.
Yes, ma'am. So one fine morning, a 32-year-old gentleman presented with right eye painless, gradually progressive diminution of the vision, and it was worsening over 1 month. He's an auto driver by profession. There's no history of redness or any pulmonary or skin issues. His uncorrected right eye visual acuity is 636, best corrected 612. Both eyes anterior segment examination was unremarkable, IOP normal, and the left eye fundus examination was normal. This is the right eye fundus photo, which shows that the media is clear, the disc margin is blurred with dull foveal reflex with some RP pigmentation and pigmentary clumps and RP atrophy. And within 1 disc diameter of the nasal optic disc margin, there's a 6 disc diameter elevated dome-shaped lesion with with overlying retinal vessels and no hemorrhages above. There's also a collection of subretinal fluid around the lesion. So this is our working diagnosis: choroidal tubercular granuloma, sarcoid granuloma, choroidal amelanotic melanoma, choroidal metastasis, and choroidal hemangioma. We proceeded with the ocular investigations: optical coherence, ultrasound, autofluorescence, and fluorescein angiography. This is the macula foveal architecture was maintained, although there was some parafoveal collection of the subretinal fluid, and across cross line across the lesion shows that there is a large RP elevation. There's distortion of the outer retinal layers along with hyperreflective material, and contact sign was also appreciable in this scan. The autofluorescence, the right eye showed some mottling and stippling in the supratemporal region in the fovea, and in the left eye also we can appreciate some pigmentary changes around the macular area and around the retinal vascular arcade. The right eye ultrasound, A scan showed moderate internal reflectivity. It was an acoustically solid lesion with no choroidal excavation, a sharp anterior border, no acoustic harrowing or any pulsation or vascularity. We had done the fundus fluorescein angiography. In the early stages, we saw in the superior, we'll talk about two lesions here. One is the superior temporal one and the nasal one of the right eye. So the superior temporal one, we see diffuse hyperfluorescence, and the nasal one is also in the early stage. There's diffuse hyperfluorescence, and it is gradually increasing in size and intensity. And in the late films, we also see that there is pooling of the dye, suggestive of the neurosensory detachment there. Apart from that, we see the hot optic disc with fuzzy borders. So we had gone with the systemic tests, and all the immunological and radiological tests came negative. Other etiologies were also excluded. So right now, the most favorable diagnosis is tubercular granuloma because it's an endemic disease because of the profession of the patient. Although, because the immunological tests and radiological tests are uh,
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 Dr. Tanya, your network is a bit spaced out. Could you try reconnecting?
okay.
Yeah.
Okay, ma'am. I'll just try
Please check
it.
your Wi-Fi connection, please.
Stop your video, and I think that Dr. Basu, would you like to fill up something meanwhile?
Yeah, I mean, I think the real thing was to look at the differentials, and especially when the tests that had been negative, you would want to examine each differential very, very carefully. However much tempted you are to call it whatever you thought, in this case, a tuberculoma, and that's why this table that she came up with is very, very important. I'll let her talk on that. The other thing is, what about the temporal lesion? The nasal lesion is very stark. It's, staring at us. But what about the temporal lesion? Was it active or was it a healed lesion? I think, the angiogram is not very useful in telling us. And the autofluorescence also is not covering that temporal lesion very well. So that would have been important as well.
I think she has joined back. Maybe Dr. Tanya, can you try to reshare again?
Yes, ma'am. Which was the last slide, ma'am?
You were on the two with
The table.
yeah,
The table with the
Here?
this one, yeah.
Yeah.
Make it full screen.
Yeah.
So, being an endemic disease, the first differential is the choroidal tuberculoma. The profession of the patient, the OCT, ultrasound, and fluorescein, which are matching with the diagnosis that we are thinking. Although the immunological and radiological tests are negative, we can still think that this is a case of a presumptive TB based on the clinical findings. So, my provisional diagnosis would be isolated choroidal tuberculoma with no systemic tuberculosis. So the patient, under the physician's guidance, was started on antitubercular therapy, and 2 weeks after, so under ATT cover, oral steroids were started. And here we can see 6 weeks after the lesion just melting away, the subretinal fluid collection has been gone, and there's a leaving behind a very stippled appearance of the overlying RPE here. So that will be the last slide of my presentation.
Can I share my slide now?
Please.
Yeah. I hope the slide is visible.
Yes.
So, this was an interesting case, and you could talk on many things. I would say the most important thing to discuss in this patient was how to differentiate tuberculoma, an inflammatory lesion, infectious inflammatory lesion like a tuberculoma, from other inflammatory lesions and from masquerades, very importantly, the melanoma and the metastasis, as well as something like a choroidal hemangioma. I think that is the most typical, most important thing in this case, and that has been discussed. So I'll stick to just one point in this presentation, which is the negative test. Okay, so both the tests, the PPD test as well as the IGRA, were negative in this patient, and we do come across this scenario not very infrequently in our clinical practice. So how do we deal with this? I'm sorry, I forgot to mention my name in the title slide. Okay, so dealing with the negative TB test, how do you go about? First is, like was done for this patient, go back to the clinical signs and the imaging. Look at every detail. Okay, look at the features, the color, the imaging signs. Take every clue from the imaging. Now, one thing in the imaging of this patient was, what we were seeing on the OCT was mainly subretinal fibrin. I'm not very sure if we can call it as a contact sign, because the contact sign requires disruption of the RP Brooks membrane, and it's like the choroid bursting into the outer retina. That when you see that kind of picture, then you contact sign. Now, I'm telling this because I have learned this myself very recently, and there have been a couple of cases of VKH with choroidal granuloma, which had a subretinal fibrin, which I thought initially as a contact sign. So we should not mix up the subretinal fibrin with the contact sign. Anyways, so these are many other signs that you look at. Look at the other inflammatory signs, like Sir was mentioning in the previous case of lymphoma, chamber inflammation, the other signs of the red eye, all those things. And the presence of absence of those other inflammatory signs will take you in one direction or the other. So this is very, very critical in these cases. However much convinced you are that TB can present with negative TB tests, you still have to go back to these differentials. Second thing is, find alternative evidence. Now, in this patient, of course, an HRCT has been done, but you have to do probably a combined CT scan of the abdomen as well as thorax, because sometimes you will find some evidence in the abdomen, a granuloma in the liver, or lymph nodes, para-aortic lymph nodes in the abdomen. So that helps. Look for other evidence of extrapulmonary tuberculosis. And again, the most important evidence is that of lymph node tuberculosis. So you might not be able to do a good lymph node examination, but send the patient to a physician for a thorough lymph node evaluation. Of course, any other thing that might be suggestive of a different extrapulmonary TB would be very, very useful. Now, one interesting thing that we learned from this patient is the history of TB contact. Now, the typical question that we ask our patients for TB contact is, did you or anyone in your family have TB? And that's the end of the story. No, it cannot be that. Okay, we have to be really, really intense in our history of TB contact. And in this case, this was an auto driver. Now, you might say, so what? There are thousands of auto drivers in every city. What does it matter? But these are the people who are in such close contact with just thousands of random people, every other day. And sometimes the auto driver will even tell you that, most of my passengers go from the railway station to the district hospital. Okay. The ideal scenario to get a TB contact. They transport patients from one place to another. So this is one picture. The other picture is migrant workers, for example. Another picture is of barbers. Very easy to get TB contact. Recently, I have had a beautician. So, barbers, you think mainly of, males having this, but a beautician coming with very clear evidence of, ocular tuberculosis. So TB contact is not a small history, it's a very elaborate history. We should go for it. And just like you are striving very hard to look for an alternative evidence of TB in the patient, you should strive equally hard to look for an alternative evidence of a non-TB diagnosis. So in this case, for example, metastasis is an important differential. So do everything in the world to look for, primary in this patient from where the meds could have come. If there is something where a repeat blood test would help, do that repeat blood test to, reach the diagnosis. So you should be equally, eager to look for an alternative diagnosis. And finally, the importance of repeating TB tests. Now, as I'm going to tell in the later slide, that these TB tests, be it the MON2 or the quantiferon, these are basically looking at the memory T cell response in the blood or in the skin. And the memory T cell response against TB is something that evolves over time. There is a certain window period. So when you have done it in the beginning, it may be negative. It's usually advised to repeat it after 12 weeks when the window period goes away and you can get a positive test. So these are three important things that we should keep in mind. Now, how common are TB tests in extrapulmonary TB in general? And I like to quote this study from South Korea, where they did just quantiferon TB gold test in every patient of their extrapulmonary tuberculosis. Now, there are many interesting things that you learn from this. And remember, this is a compilation of all extrapulmonary tuberculosis, not just one type. And the first thing you see is that even for other extrapulmonary TB, probable and possible extrapulmonary TB are more common than proven or microbiologically proven TB. So it's not that ocular TB is the only type of TB that remains microbiologically not proven. Okay, so probable is way more common than proven TB. And in each category, the red and the green that you see here, these are either negative or indeterminate quantiferon tests. So you see that in each category, there's a fairly big chunk of patients who are having negative quantiferon TB gold test. Okay, they didn't do any MON2 here. So together, about 30%, and that's a big number, almost a third of your extrapulmonary TB patients are quantiferon negative. And as seen here, it's more common with possible than with probable or proven TB. And very importantly, I'm not showing the data here, but CNS TB, the chances of having a negative TB test is way more than the other extrapulmonary TB. And knowing that the eye is very similar to CNS TB, we should also expect more negative TB tests in our patient. Okay. Now, this is a study published from the Armed Forces Institute of Pathology in the US, where they had the histopath samples of microbiologically proven ocular TB, all of these. And there, in the very small numbers that we have, 40% had a negative MON2 test and 57% had a normal chest X-ray. So even in microbiologically proven ocular TB, you can have negative MON2 test and chest X-ray. So, should keep it at the back of our mind. So why are we getting these negative tests? That's because of the window period that I just mentioned. It takes time for the immune response to evolve. And this is a figure from a paper published in 1999, where they showed that it usually takes about 6 weeks for the immune response from the time of the primary infection. And usually the max it takes is 12 weeks. So it is recommended that you should repeat, in case you're strongly suspecting TB, you should repeat the test after 12 weeks of the first test to cover up for the window period. Now, this is only one cause of a negative MON2 test. The other causes are also very important. And these are a faulty technique. Okay, so you are supposed to give this injection intradermally, the MON2, but if you give it subcut, you're not going to get the response. Most important of these is probably faulty reading. Okay, we all depend on the lab technicians' reading of the MON2 response. But what is induration? What is the erythema? That has to be read by a very trained technician. Okay. Similarly, poor quality tuberculin. Now, tuberculin has to be maintained in a cold chain. If the lab is not serious enough and not maintain the tuberculin, it's not going to work in the Montu test. And then there are biological reasons like a miliary tuberculosis or HIV, any other immunosuppression, neutropenia. Young patients, these are more likely to have a negative TB test. So, we should be all aware of these factors. And finally, I want to introduce you to this statistical concept called uncertainty. Okay, so uncertainty is the inverse of predictive value. So what happens when you have a very strong suspicion of a particular diagnosis, but your test comes negative, okay, which is the second part of this figure, then you are likely to have a false omission rate. Okay. On the other hand, when you have very low suspicion, low pretest probability of a particular diagnosis, but your test comes positive, then it's called a high false discovery rate. Okay. So your clinical suspicion or the pretest probability is very important, how you interpret your lab test. And finally, I'll show this more, drastic case that I had some time ago. This came in 2018. And there were these choroiditis lesions in both eyes, the right eye being smaller than the left eye. And the patient had a, negative Montu test and a normal CT thorax. The TB contact was not there. We just casually asked the history. And so we treated the patient with steroids and sorry about that. And the lesions went away entirely. Only thing that the patient came back with a huge lesion, which is a year later. And this is when we started the patient with anti-TB therapy alone, no steroids at this stage. And you can see in 2 weeks, they're melting away. And in 5 weeks, they're gone completely. So, this is what can be happening to the patient. Thank you very much. Any questions? I'll be happy.
Thank you. Thank you so much, sir. And thank you, Dr. Tanya. TB is our favorite topic, and no better person to listen all this to and learn from than Dr. Basu. So, sir, as expected, we have a lot of questions in the chat box. So
I'm scared.
so I'm just gonna start with so the first question is, can't we start oral steroids with ATT rather than after 2 weeks? Any difference does that make?
I think you can very well start oral. I always, whenever I'm giving steroids, I always start with ATT. There's no question to wait for 2 weeks. We had this. Sir wants to say something?
I also do that, same thing.
Yes, sir. Yeah.
So, need to wait, like Toxo.
Yeah. The only place where I'm a little hesitant in starting at the same time, and others may have a different opinion, is acute retinal necrosis. Of all the infectious uveitis, that is the only one where I wait for a few days to look at some response before starting steroids. But I know many experts who start steroids at the same time, even for acute retinal necrosis.
No, I think antiviral, yes, as you said, always you wait for some time and then start the steroids.
TB, especially when the lesion is near the disc and near the macula, steroid is a must. Because there may be rebound inflammation and which can eat away macula and the disc.
Right.
And in this case, we had not given steroid at the same time because he had already responded to steroids earlier. And, this was such a large lesion, we were worried that we won't be able to figure out what is the diagnosis, especially with the negative Montu test. We followed very, very closely.
Yeah.
Another question is, in your experience, have you seen a posterior pole lesion with MANTU positive and toxoplasma IgG and IgM positive with a positive contact sign? So how do we go about this?
Of course, I mean, I need to look at the picture before, commenting on this. But, I will never test for toxoplasma IgG, IgM in a typical case of ocular toxoplasmosis. Okay, it's only in the atypical cases. And here again, the role of toxoplasma IgG is to rule out toxo.
Yeah.
So negative IgG is more important than a positive IgG, because if you have a negative IgG, you are very sure you are not dealing with toxoplasmosis. Positive IgG is not going to help you much.
I agree with you.
There is a chance that, especially in immunocompromised patients, that you can have a mixed infection, and we have been talking, about this recently in our group at LVP. But that's typically in immunocompromised patients. But having a toxo IgM positive, as well as a lesion which sounds, from what you said, very much like a TB choroidal granuloma with a contact sign. One thing to answer your question is that TB will be a chorioretinitis when we are talking in terms of the contact sign. It's a chorioretinitis. Whereas toxoplasma is a retinochoroiditis. So it will first have a full thickness retinal involvement before involving the choroid. So that chorioretinitis versus retinochoroiditis should be very carefully observed.
Right. Excellent point, sir. Other question by Dr. Harshvardhan. Significance of serum ACE levels in ruling out ocular sarcoidosis. And he has two questions. What is the significance of conversion of a positive PPD result into a negative one in diagnostic clue towards sarcoidosis? So both are regarding the same. Yeah.
So, this is, I know many people might have a different opinion, but if you look at the sarcoidosis literature, sarcoidosis is a biopsy diagnosis, and it cannot be diagnosed by any kind of blood test, whether we are talking about, serum AC or lysozyme or calcium or whatever. It cannot be diagnosed by a blood test. It has to be a biopsy diagnosis. So what we teach our fellows is to focus on the organ-specific involvement. Now, one organ-specific involvement, of course, is the lungs and the mediastinal lymph nodes. And whenever we get a chance, we do try to get a EBUS or a lymph node biopsy. Sometimes you don't even need an EBUS. You can just do an axillary lymph node biopsy or a cervical lymph node biopsy to reach the diagnosis. The other thing that we do, and this would be relatively rare, is to look at other involvement of sarcoid. And the one that we come across most commonly is skin involvement, the erythema nodosum, and the other is the neurological involvement, which is the Bell's palsy. So many people may not be having the Bell's palsy at the time of uveitis, but they will give you a history of. This is not very common, but sometimes these are the ones that fetch the diagnosis. And then what we have learned from Dr. Kalpana's study is about looking for a Sharma test and looking at dry eye, a way to differentiate sarcoid from TB in endemic countries. So these are things we focus on rather than doing the serum ACE, which will depend on the total load of granuloma in the patient. If the load of granuloma is not very heavy, then the serum ACE is not going to help you very much.
Right. Another question, sir, is how often do you get a PET scan done in suspected ocular TB patients? This is not specifically if the phenotype is suggestive of TB, but otherwise when in doubt. And so that is the question.
Yeah, I rarely get it done, but to be honest, I would love to get it done in every patient that I'm suspecting TB. You have to remember that the PET scan is also an exposure to a lot of radiation, okay, apart from the cost of the PET scan. So, we are not so, aggressive in getting PET scans done. But from a science perspective, I would love to get it done in every patient where I'm suspecting TB. Having said that, I'll tell you one thing which I have changed in my practice. Now, when I'm suspecting sarcoid, a CCT thorax is a must. By the way, I was getting HRCT for some time in between, but I realized that it's CCT which will be helpful. So sarcoid CCT is a must. Rich patient, poor patient, I see whatever I can do to get it done. But for TB, except in cases where I see focal lesions, so for example, this patient, which was presented, or there's a multifocal, choroiditis see those choroiditis lesions, or you see a retinitis lesion, some kind of a focal granuloma I'm seeing in the eye, those are the only ones where I get a chest imaging done. Other than that, in a patient who doesn't have any systemic involvement, a chest imaging is not going to change my diagnosis. So I don't get it done so frequently in my TB patients anymore. So that's one thing that I've changed in my practice. And I don't test for TB in every patient. Only when I'm seeing those particular clinical signs, I look for TB. I don't test a Montu or quantiferon in every uveitis patient.
Another question, sir, is do you consider contact signs specific for TB?
I think contact sign, if interpreted properly, like I told you, I myself learned this very recently. At least there are 2 patients I know where it was actually a subretinal fibrin, and I kept calling it contact sign for a long time, like in this patient as well. But contact sign, if you see an actual bursting of the choroidal inflammation into the outer retina, I call it bursting, with the Brooks membrane and the RP gone. That is a sign of chorioretinitis. And chorioretinitis is, a very useful way of diagnosing tuberculosis. Yes.
Right. So sir, we have many questions in the chat box, but due to the paucity of time, I firstly would like to thank all the panelists for this really amazing, discussion that we had today on all the 4 topics. And so there are a few questions. Would request you to please answer them in the chat box for our participants.
Yeah.
Now I request Dr. Parthu sir to please take this forward with today's quiz.
I would like to interrupt. I just want to ask one question to Dr. Basu about the role of anti-VEGF when you're dealing with a choroidal tuberculoma. Because
And,
what I
yeah, go ahead. No, I use anti-VEGF a lot more sparingly than a lot of people do. I believe the VEGF levels are high in almost any form of inflammation. If you have literature on VEGF levels in endophthalmitis, you will see that the levels are 10 times that of what we have reported for ocular tuberculosis. Okay, so higher VEGF is an inflammatory marker more than a pro-angiogenic marker. Okay, so more is the inflammation, more will be the VEGF. Okay. That said, it is now very well established how VEGF helps in the dissemination of the tubercular granuloma, and in that sense, anti-VEGF therapy should help in treatment of a choroidal granuloma. I think I use it in cases where, for example, I see a RAP lesion or a vascularization of the granuloma, especially if it's visible on ICG. That's when I use it more commonly.
Thank you, sir. So we would now invite Dr. Parthu to carry forward with the quiz.
Yeah, thanks. Just first we'll go to the video by Veda, which will give you the answer to the last question. So log out.
Doctor, you're not audible.
You're not audible. Please reconnect to the audio. Miss Veda?
Not audible?
No, not audible, sir.
I was playing the recording.
No, sir. Sorry.
So you can stop share. Share again with audio, sir.
Yeah. Is it audible now?
Good evening, everyone. This is
Yes,
discussion
yes,
of
doctor.
last week's quiz. So, 45-year-old female who presented to us with unilateral pain, redness, and her clinical picture. You can see that there were few granulomatous KPs in the anterior segment and few KPs were very close to the angle. And in the posterior segment, she had snowballs and AVH cells. So anatomically, this is granulomatous anterior with intermediate uveitis, and your main differentials will be TB and sarcoid in this patient. So MANTO was negative, PT chest was normal, serum ACE was also normal, because in few cases of ocular sarcoidosis, your serum ACE can still be normal. Other infective causes were ruled out by appropriate blood investigations. So here, because of the female sex, angle KPs and the typical snowballs, a diagnosis of ocular sarcoidosis was made. So she was started on topical and oral steroids, but because the inflammation was persisting, immunosuppressive methotrexate at the dosage of 15 milligram per week was added in the patient, and she responded to the treatment. So while on immunosuppressive, she developed lid edema, severe congestion, and you can see that patient has keratouveitis and there were few KPs on the endothelium with associated IOP rise. Now you can see the clinical picture has changed from the previous granulomatous anterior with intermediate uveitis to now keratouveitis. So here the diagnosis is viral keratouveitis. So the same was confirmed by ACTAP with PCR analysis. PCR was positive for viruses, and she was started on oral antiviral, and there was improvement in the clinical picture. So the initial picture was sarcoidosis, and while on methotrexate, she developed viral uveitis and was started treated for the same. Thank you.
So let's see who is the winner for this quiz. So total, I think 24 people answered correctly. So I'll just spin it and pick up the lucky winner for this quiz. So the winner is Prayagi Kandot. Congratulations, Dr. Prayag. So we'll contact you from the UVI Society of India office. Now, may I invite Dr. Nitin Kumar, who will be conducting the brain buzz of this episode of webinar. So Dr. Nitin is an associate professor who is working in AIMS Jammu. Over to you, Nitin.
Thank you so much, sir. Thank you for this opportunity. Yes. Yeah, I hope my slides are visible.
Yes, sir.
Yes.
Yes.
So I'll be explaining few of the slides, not all the slides, so that the participants can just guess what is the condition and answer correctly. So this was a 59-year-old gentleman who presented to us with bilateral diminution of vision for last 4 weeks, and there was no history of any systemic illness. When he presented to us, his visual acuity was 6/36 in both the eyes, and intraocular pressures were normal. There was some posterior subcapsular cataract in both the eyes, but the anterior segment was quiet. So these are the anterior segment photographs for the patient. Fundus examination showed some vitreous haze and some haze due to the posterior subcapsular cataract. And there was some, the foveal reflex was dull in both the eyes. Also, this is what was there on fundus fluorescein angiography. And these are the optical coherence tomography pictures. We investigated the patient also. There were the Montu test was positive with 20 millimeter in duration. CECT chest was also suggestive of some infectious pathology. RPR and TPHA was negative. And so this is the question: what is the probable diagnosis and the preferred treatment? Is it bilateral tubercular intermediate uveitis, and will you treat with topical or oral corticosteroids? Is it bilateral tubercular intermediate uveitis, oral corticosteroids plus antitubercular therapy as the preferred treatment? Bilateral tubercular panuveitis with topical, and you will treat with topical as well as oral corticosteroids plus ATT, or it is bilateral anterior uveitis with topical and oral, and you will treat with topical or oral corticosteroids. Thank you. And I think the Hallmark team will provide a link for the answers.
It's shared on the Google chat, doctor.
Okay. So you can go to the chat and fill the Google form for the correct answers.
All
Thank you.
right.
Thank you, Dr. Nitin. So I would like to now invite Dr. Namita Matthew for talking about the drug of the day, that is cyclophosphamide and cyclosporin. Dr. Namita.
Good evening, everyone. I hope my screen is visible.
Yes.
The next session is Know Thy Drug, cyclophosphamide and cyclosporine, crucial drugs where caution is key. First, I'll be briefly discussing cyclophosphamide. It is a nitrogen mustard that exerts its anti-neoplastic effects through alkylation. It is primarily used in the management and treatment of neoplasms, including multiple myeloma, sarcoma, and breast cancer. The FDA-approved indications are in malignant lymphoma stages 3 and 4, breast cancer, disseminated neuroblastomas, retinoblastoma, minimal change nephrotic syndrome, ovarian adenocarcinomas, and autoimmune conditions like multiple sclerosis. Its use in uveitis is not FDA approved, but it has been used off-label. Cyclophosphamide is a prodrug that undergoes a metabolic activation by the hepatic cytochrome P450 enzyme to 4-hydroxycyclophosphamide and aldophosphamide that further gets converted to phosphoramide mustard, which is responsible for DNA cross-linking and cytotoxicity. And therefore, it exerts its effects through the alkylation of DNA. Its immunosuppressive effects of cyclophosphamide are mainly because it helps to decrease the secretion of interferon gamma and interleukin-2 and increases the secretion of cytokines like interleukins 4 and 10 in the CSF and peripheral blood, which make it amenable to be used in post-transplant alloreactivity management, immune-mediated conditions, and in vasculitis. Around 75% of the oral dose of cyclophosphamide is absorbed from the GIT and reaches peak plasma levels 1 hour later. It undergoes hepatic metabolism to cytotoxic metabolites, and 50% of which is bound to serum albumin. It has a T-half of 4 to 6 hours and is 10 to 20% excreted unchanged in urine. Its recommended oral dose is 1 to 2 milligram per kg body weight, which is preferably taken as a single dose in the morning with plenty of fluid intake throughout the day, advised to take about 3 liters. Here, I would like to quote the SITE study, the Systemic Immunosuppressive Therapy for Eye Diseases study. It was a large retrospective cohort study of about 8,000 patients with non-infectious ocular inflammatory diseases that were treated at 5 tertiary care centers from 1979 to 2005. It evaluated the demography, clinical course, treatment outcomes, side effects, discontinuation rates, the overall mortality, and specifically the cancer-associated mortality with individual immunosuppressive agents. Here, 215 patients were treated with cyclophosphamide, of which 76% achieved inflammatory control at the end of 1 year. And those who received the drug orally had a higher rate of inflammation control than those who received it IV. And there was no significant increase in the overall mortality. However, there was a possible increased risk of cancer mortality. The ocular indications of cyclophosphamide are in cases of severe ocular inflammation in systemic conditions like granulomatosis with polyangiitis, rheumatoid arthritis, polyarthritis nodosa, SLE, mucous membrane pemphigoid, Behçet's disease, VK syndrome, and sympathetic ophthalmitis. The adverse effects include anorexia, nausea, vomiting, which is quite common, hemorrhagic cystitis, which is the most notorious side effect of cyclophosphamide that can be reduced with a single morning dose, adequate hydration, frequent voiding, and concurrent administration of mesna. This can occur within the first 24 hours up to several weeks after initiating the drug. Other adverse effects include bone marrow depression, secondary malignancies, commonly AML and bladder carcinoma, gonadal dysfunction, hepatic dysfunction, and cardiomyopathy. It is contraindicated in cases of depressed bone marrow function, drug hypersensitivity, pregnancy, and lactation. Drug monitoring of utmost importance. This includes a complete blood count weekly to bi-weekly till the stabilization of parameters. It must be avoided if the WBC count drops below 3,000, neutrophil below 1,000, or platelet below 70,000 cells per milliliter cube. A granulocyte colony stimulating factor can be given to reduce the effects of neutropenia and infection risk. Urinalysis periodically is also recommended to evaluate for the presence of hematuria, proteinuria, or bacterial infections. Coming to cyclosporine, it is a calcineurin inhibitor that inhibits T cell activation. It was first used as a clinical immunosuppressive in 1978 in renal transplant patients. Nusenblatt et al. Found it to be effective in the treatment of experimental autoimmune uveitis in an animal model and first published results for a small group of patients with uveitis in 1983. Cyclosporine binds to its receptor cyclophilin 1 inside the cells and produces a cyclophilin complex, and this complex inhibits calcineurin, which further stops the dephosphorylation and activation of NF80. NF80 is nuclear factor of activated T cells, and this is a transcription factor that promotes the production of cytokines such as interleukins 2, 4, interferon gamma, and TNF alpha. The inhibition of interleukin 2, which is needed for T cell activation, is believed to be responsible for cyclosporine's immunosuppressive actions. Ocular indications are in case of Behçet's disease, birdshot chorioretinopathy, sarcoidosis, pars planitis, VK syndrome, sympathetic ophthalmitis, and corneal graft rejection. Pharmacokinetics. Nusenblatt et al. Had initially used cyclosporine at a dose of 10 milligram per kg per day. This was associated with a 100% incidence of hypertension and nephrotoxicity. Towler et al. Used lower dose cyclosporine of 4 plus minus 1 milligram per kg per day, either alone or with corticosteroids, and found an improvement in visual acuity in 85% of cases and a reduction in vitreous inflammation in 97% of eyes over 2 years. There is no reported efficacy in treating uveitis with topical cyclosporine. The site study involved 373 patients treated with cyclosporine, of which 52% on monotherapy attained remission and 36% could taper the systemic steroids to less than or equal to 10 milligram per day at 1 year. There was no increased risk of mortality or cancer. The side effects are most commonly nephrotoxicity and hypertension, which warrants periodic checkup of renal function tests, gingival hypoplasia, increased susceptibility to infections, electrolyte imbalances, mainly hyperkalemia, hypomagnesemia, tremors, hirsutism, and sometimes pancreatitis and hepatotoxicity. Thank you.
Thank you. Thank you, Dr. Namita. I would request the panelists to share their experience with both the drugs. Of course, cyclophosphamide, Dr. Ratnam had shared extensively. Uh, Dr. Ratnam, any experience? Please share your experience with both the drugs for our listeners.
Ratnam ma'am is not online, doctor.
Okay. Sir, Dr. Basu.
Yeah, so I mean, ma'am has already discussed about cyclophosphamide, so won't go into that, except that, you know, I have stopped using oral cyclophosphamide for a while, mainly because my patients were not getting it, and at least in Hyderabad, the rheumatologists were recommending against oral cyclophosphamide. But we do use IV, and I think, like ma'am said, it's a wonder drug. You know, it needs to be used. It's, you know, unnecessarily people are worried about the side effects of this thing. But I want to tell a thing about cyclosporin. Okay, we all heard you know, the mechanism, dose, etc. Of course, the use of cyclosporin has come down drastically compared to what it was, let's say, 10 or 15 years ago. Now, for example, mycophenolate is used so much. But cyclosporin has one another interesting function. And this function is to block a certain channel in the immune cells called as the multi-drug resistant protein, okay, MDR protein. It's also one of the forms of MDR protein is called as P glycoprotein. Okay, now what this protein does is that any xenobiotic that comes into the cell, and this includes any drug, okay, so any xenobiotic that comes into the cell, it throws it out. So whatever drug you are giving to the patient, it will be thrown out by the cell. That's the natural, you know, physiological thing. And cyclosporin blocks this this channel. So if it blocks this channel, it acts as a very good adjunct for the other drugs to work. So this we have published also at least a couple of papers using cyclosporin, you know, and showing the effect on both the vitreous immune cells as well as the blood immune cells. So that's, you know, just for the sake of information, I thought it should be known as well.
Right. Thank you, sir. And I would like to thank all the participants and all our esteemed panelists for this really informative webinar. And thank you, Partho sir, for this opportunity. And thank you, Dr. Neha, for co-moderating this webinar. And we are looking forward to the next webinar already. So thank you, everybody.
Thanks, everyone.
Thank you. Thank you all.
Okay, guys, thank you. Good night.
Good night, sir.
Shabina?
Preparing dinner, sir. Preparing dinner, sir, Shabina ma'am.
Okay, bye.
Bye, sir.
She will leave, or I mean, she'll end the meeting.
Yeah, sir,
She
will
will
inform.
inform Madi.
Okay, sir. Okay. Bye, sir. Good night.